G'day everyone. I'm Megan Williams and I'm Wiradjuri and belong to Northeast Wiradjuri country and community. And I'm coming to you from Davey Lands, Northeast Wiradjuri, which is connected to my mob in Mudgee through the Kudgegong, the river nearby. I acknowledge ancestors and elders of the past and elders of the present, this community and all the lands that you're coming to us from today, and acknowledge all the contributions that Aboriginal and Torres Strait Islander community members make to this nation and to this topic of prison healthcare, prison health services, and acknowledge the black and deadly future that we've got with biggest mob young people coming up. And part of us being here is Croakey's commitment to the intergenerational transfer of knowledges, and we've got people among us today with some considerable experience about prison health service delivery that we want to document to pass on. And I acknowledge all Aboriginal Torres Strait Islander people with us today. There's lots of mob here and many familiar faces. So Mendangu, thank you so much to each and every one of you for coming along today. And I'd like to dedicate our time together today to the more than 560 Aboriginal Torres Strait Islander people whose lives have been lost in correctional centres and in police operations, and their families as well. And we always keep in mind that families and communities are wholly affected with people in prison and the passing of people in prison as well. And ultimately, we're here to prevent deaths in custody, absolutely, but also prevent incarceration. So while Croakey speaks about prison health services in Just Justice, the online series, and in recent preview articles to this webinar, for example, we are absolutely clear about reducing numbers of people in prison, reducing risks of incarceration. And we speak about prison health services because there are so many currently in prison with multiple and compounding health issues that often urgently require healthcare. But we can talk much more about that. I'd like to just do a little bit of housekeeping, and there'll be some housekeeping notes in the chat as well. But I think all of us will have our mics on mute when we require that. And also we'll be live tweeting with Mark Wenitong from Croakey. And there's some hashtags: Croakey Live, Medicare 40 years, Just Justice, and improving prison healthcare to follow along with. Feel free to post comments in the chat and questions, links to resources. I know there's some handy, resourceful people among us here. Anything that you want private, though, absolutely, you need to take action to keep that private. Direct message. And a reminder that this is being recorded and it'll be published at croakey.org. So sort of privacy confidentiality note there. And also just in terms of setting up to say thank you so much for the panel members who we'll be hearing from. And then also the sponsor, which is Yulang Indigenous Health Discipline at UTS. And on that, the funds have come from the Indigenous Mental Health Intervention Project, tricky name, the youth project that's underway in Queensland, working on models of mental health care for young people in detention centres. And I'd like to just give a shout out then to colleagues Penny Dale and Marshall Watson, Aboriginal colleagues Arnie, Cindy Sinclair and Mandy Dooch, who've got a role in cultural governance of that project, and our colleague Professor Ed Heffernan. We've worked together for many years. And then also tomorrow, I think the AIHW report on Aboriginal Torres Strait Islander people in prisons health comes out. So just a shout out to dear colleague Jocelyn Jones, Dr. Jocelyn Jones, who's with us today here, and our other dear colleague, Associate Professor Michael Doyle. Michael, Joss and I worked with others, Professor Tony Butler, who should be acknowledged for some of his early research work in this field, and also Professor Stuart Kinner too, and our colleague Dr. Jill Guthrie, and then we come back around Auntie Julie Tongs, and that's where we first met around maybe 15 or more years ago. And also to mention Croakey's Just Justice work and our dear colleague Summer May Finlay, who's got a deadly role with Michael chairing ethics committees. So research ethics is sort of on our minds today as well. And that Just Justice work in Croakey's board too. Croakey also has done outstanding work with Katsanam, College of Aboriginal Torres Strait Islander nurses and midwives. And just to flag that we don't have the nurse contribution today, but that's on our mind, and most prisons have a nurse-led model of care. So we're thinking pretty sharp about, well, the gaps in curriculum about prisons in nursing education and the great demands on nurses generally, and where those professions might go in the future and how that fits with Medicare. And there's so much other Aboriginal Torres Strait Islander leadership that we won't be able to sort of mention today in our short time together. But a couple of final shout outs to Victorian Aboriginal Legal Service, Victorian Aboriginal Community Controlled Health Organisation, and especially their very recent advocacy using the Victorian Ombudsman's report into prison health services that Jack and I worked on, and Jack might talk a little bit more about that. So yeah, there's certainly a lot of activity, and including the NAS review, and any insights people can give to that, I think would be welcome, given that it's not yet reported and people are eager to understand some of its content and directions. So this webinar, yep, it's part of Croakey's Medicare 40 Years project, the 40th anniversary, in case that makes some of you feel young or old. And it's such a critical opportunity for advancing important health reform. And we know about that through the Closing the Gap overlay and the priority reform about the way government does business with Aboriginal Torres Strait Islander people. So this absolutely fits in. And it's here as a platform for our discussion and for all of you to contribute to the media as a determinant of health of Aboriginal Torres Strait Islander people, and the shared determinants of health and justice, and media as a determinant of justice, and the tough on crime proponents that we are often overwhelmingly, I'll say victim to, but faced with. And so over to our panel members. I'll introduce you all, and then we'll to speak. I'll introduce you all overall, and then invite one at a time to speak. So firstly, Auntie Julie Tongs OAM, Wiradjuri woman and CEO of Winnunga Nimmityjah Aboriginal Health and Community Services. And this is a topic Julie's spoken about in depth and very strongly many times, and I can quote you on saying it's your favourite topic, but it's also quite a horrendous favourite topic. So our deepest respects to you in that regard. And then Dr. Mark Wenitong, who's Kabi and a long-term senior medical advisor with Apunipima, Cape York Health Council, and long-term experience with prison health service delivery, coronial investigations, including with families as well. And Jack Bullman, a Muddy man, southwestern New South Wales, and he's worked as Chief Executive Officer of Nimmityjah Spirit Healing, a community-controlled, community-based health promotion charity, which has worked alongside people and families affected by criminal justice system, the legal system, and his work too on fathering. Wonderful topic. So I'm going to introduce and ask Julie, will you have a say? About 5 minutes?
Absolutely. I'd like to start by acknowledging that I'm on the land of the Ngunnawal and Ngambri people and pay respects to elders past and present. I'd also like to acknowledge other Aboriginal and Torres Strait Islander people online and on the panel, and particularly Megan and Dr. Mark Wenitong. We all go back a long way, and Winnunga has had an interest. I started at Winnunga in 1997, and in 1998, Dr. Peter Sharp and I met with the heads of corrections here in the ACT. We had a remand centre. We didn't have a prison, and we had a lot of intravenous drug users back then, and it was heroin. And we were horrified that they were being treated with Panadol. So it probably took me about 6 or 8 months to argue the case, and we were able to go into BRC and see our clients and be able to prescribe methadone. So, and for those that were already on the methadone program, we were able to continue it. In 2001, we were approached by the AHMRC and New South Wales Corrections to provide a service to the inmates in Goulburn Jail, the Aboriginal inmates. So we provided a service on a Wednesday. At that time, we only had around 10 or 15 men in the prison, and we were able to go over there on a Wednesday, Dr. Pete and an Aboriginal support worker, and provide a service to them, and we did that for 10 years. Then we went to Cooma Jail when they reopened the minimum security at Cooma. The men that were transferred from Goulburn wrote to New South Wales Health Corrections and asked if Winnunga could provide a service to them in Cooma. So we went to Cooma once a month on a Friday. Then in 2009, the prison here opened, and even then, the fellas that transferred back from New South Wales or were sent to prison here in Canberra, it was only small numbers. So Dr. Pete would go out on a Friday, and my social health team would go out and see them through the week. And the Aboriginal staff are the conduit between the prisoner and the families. So that's really a really important connection. But in 2015, we had a young man, Stephen Freeman, who was severely assaulted in the AMC, and was taken from the AMC to the Canberra hospital within 3 hours of being sent to AMC. He had serious head injuries. He was in intensive care for 6 days and then sent back to the jail. In 2016, on the 27th of May, Stephen died in the jail from a methadone overdose. No one was ever found to be responsible, but in January 2016, Stephen had a toothache. He asked to go to the dentist. He couldn't see the dentist until April. In April, the dentist was on leave. Then he asked to go on the methadone program. Then he died in custody. As part of the inquiry, I sat with the family and with Philip Moss, who was an integrity commissioner, who chaired the inquiry, and we were looking for questions as to why and who assaulted Stephen, and the family never ever got the answers that they were looking for. So, and one of the recommendations from the Moss inquiry was that Winnunga be integrated into the AMC to provide to be integrated with Justice Health. But after the coronial inquest, I walked out of the coronial inquest with our executive director of clinical services and said, under no circumstances are we going to be integrated. We're going to stand alone because I'm not prepared to share their risk. So then I argued and fought, and I got the Minister for Corrections at the time, Shane Rattenbury, to come to a NATCHO board meeting and announce that Winnunga was going to stand alone in AMC. So we're autonomous in AMC. We have doctors there. We provide a service 365 days a year, 7 days a week. And our doctors are on call after 8:30 at night. When the men and women go into lockdown around 5 o'clock in the afternoon, then nobody can get to see them. What happens is that the staff ring the doctor or the nurses and they explain to them what's happening with that detainee or prisoner, and that's how we get the information. It's very risky, you know, because there are no clinical services overnight, and when the doctor gets called in the middle of the night, he needs to make a judgment call on whether that person needs to go to hospital via ambulance or not. It's not an easy thing to do to run or it hasn't been for us anyway. So in 2019, when we went in there to run our full-time clinic, we've had a lot of pushback, not just from corrections, but also from Justice Health. And so it's been challenging. And I think what people need to understand is that MBS, I truly believe that it should be in prisons, but it wouldn't cover the salaries of the staff that are in the prisons delivering the services. So there has to be a balance if there was going to be MBS. But even PBS, it costs a lot of money to provide medications. So they lose access to the MBS as well, PBS. So for us, you know, we provide doctors, nurses, clinical psychologists 1 day a week, a forensic psychologist, an Aboriginal support worker. We do justice reinvestment, a forensic psychologist that provides DBT, CBT, and the RUSH program. We have a mental health nurse that goes out and does the mental health care plans. We have a psychiatrist based at Winnunga where we can do video, telehealth if we need to. So pretty much what we do at Winnunga, we can do in the prison. We've now, our optometrist has gone out there 1 day a month. And some of that's the existing services, but AMC is just an extension of what we already do at Winnunga. So we're one service. We're Winnunga, Narrabundah, and we're Winnunga AMC. When them nurses aren't working out at AMC, they're here at Narrabundah. So there's continuity of care for our clients as well. Is that
amazing? Thank you so much. Yes, spot on, and Julie. All the points and timing, and yeah, what a diverse workforce that you've got, and that continuity of care, because prisons are part of our community rather than separate, and you're demonstrating that, leading that. So yeah, thank you very much. I'm sure a lot of that's resonated with you, Mark, Dr. Mark Wenitong, Uncle Mark, and we'll ask you to share your experience and your calls to action.
Yeah, look, it has to resonate with me, or because Julie's my boss, really, in life. Okay, I learned a lot of things off her, particularly how to operate in Canberra, and get things done. And if any service was ever going to be able to get a health service up inside a prison, was going to be Winnunga, for sure. And I don't know how you did it, but that is brilliant, I think. Look, my background, my mum's Kabi. I've got a long background in North Queensland, particularly in prison health. So doing the prison health clinics up this way, and then part of that has been part of our men's health stuff that me and Jack have been doing for a long time too, and Megan for that matter. And so these are all interconnected, and I think for me, the big driver at the moment for me in prisons is the fact that, like, we've got all this new evidence around adverse childhood experiences, things like that. The biggest adverse childhood experiences in our communities are probably domestic violence. The biggest bunch of people that we can actually work with for healing are in prison for domestic violence at the moment. If we want to see generational change in not just, I'm talking domestic violence here, but we're talking about adverse childhood experiences, that leads to chronic diseases, mental health issues, and substance abuse issues later in life. If we invest here, we'll see good outcomes. Like, we'll see improvements, generational improvements. And let's face it, look, I'm a prison doctor. I mean, I do prison clinics. So I'm not speaking naively. You know, I know there's prisoners that are proper, need to stay in prison and probably never get out. There's a bunch of blackfellas in prison though that are most amateur. They're not professional prisoners. You know, they're criminals. These are people who probably should be either getting mental health healing or other ways of taking care of the issues that they have. But prison's not the place. And I'd say that'll be the majority of our men and women. Because the ones that I see inside are not hardened criminals. These are people that stuff up, or to be honest, the system doesn't treat very well. And I'm talking about the police system and the justice system in Australia that just doesn't treat blackfellas very well. And in fact, in some states, I think the police still think they're policing the colonies to protect them from blackfellas, because of the amount of our kids that are hitting the justice system all the time. It's kind of getting a little bit out of control, some of this stuff, you know, and when you look at Western Australia as well, numbers wise, and you can't possibly have a normal, healthy generation coming through if they've been through juvie. So the feds did a prison through care program, looked at youth through care and adult through care in 3 jurisdictions a couple of years ago, and I consulted on that. And so just looking at how do we turn around that prison system instead of it being just a punishment system to a therapeutic system. And there's certainly a lot of people that would respond to that in this system. And I speak particularly about younger people in juvie, particularly, you know, like that investment would be awesome, you know. So we've got a long way to go. I think the stuff that we're talking about now around trying to get a decent health system in the prisons has been going on for a fair while, as everybody knows. You know, whether it's been private or jurisdictional run in the prisons. Because what we do know that for our mob, none of those partners have been the best at taking care of our health. That's why we had to invent community controlled health services. And that's why I think when we're talking about health services inside, particularly when we start talking about equivalency, which is, you know, what we're supposed to be talking about, that a prisoner should have the right to the same standard of healthcare inside as outside. Well, our standard of healthcare outside is really community controlled. That's the only useful standard we have of healthcare, because nothing else has really worked for us. So anything less than a very proactive, holistic model of care is not going to be that useful. And if you've worked with any of our people inside, you know this. You know this is really about healing a lot of this. And if we can get those programs inside, we can do a lot. We can do a lot. Now that's notwithstanding all the chronic disease stuff that we're dealing with at the moment, and we know that the current services are just not doing enough. And some of the reviews that I've done, it's been pretty substandard. And I say that as a doctor, and to my nurse colleagues as well. Us doctors and nurses, some of the things that are in these reports that are about duty of care are a complete breach of duty of care. From a professional health perspective, you know, the particular ones that you brought out in this, you know, as the reading for this as well, those people shouldn't have died. That's basic healthcare. That's not even racism stuff. This is just basic healthcare 101. Do you take a pulse? Did you take their blood pressure? Did you take their temperature? Those kind of things that will tell you that they've got an infection or sick or not sick, you know. These things being neglected, that's kind of a little bit worse, I think, than kind of just less than proactive, you know, like less than reactive health services. That's kind of borders on neglect, those things, because this is well-known evidence-based practice that we should all be practicing, and some of those things should just never happen. It doesn't matter where you're practicing health. And there's not really an excuse for that inside or outside. The other things are, though, that what I found is as well is that the national strategies and health strategies, particularly public health ones, really haven't really gotten into some of the target areas particularly in prisons, you know, and that went right from the initial national sexual health strategy all the way through to now. I think we've really got to do a fair bit of work there. And my last review was was looking at some services during the pandemic, and there were so few services during the pandemic because everyone got hit just as hard. But that meant that prison services as well, which were pretty tardy to begin with, were less during that time. So a lot of our people inside got less services during this time, and so there's a whole lot of catching up to do there as well. I think they could, you know, look, and I completely agree with Julie. Look, Medicare cashing it out or paying it or reinstituting it is not going to be enough. And to be honest, as I started what I started with was that the investment we can make here particularly with our men and women, but particularly men, as we know they're the largest majority in there, is huge. We can actually see generational changes if we actually start thinking through this now and stop talking about healing and start doing things about healing, you know. And on the inside, and the guys that I deal with inside, man, like I tell you what, there's anger, but man, there's a lot more sadness than there is anger. And they're the kind of things that we need, I think, going on into the future. I do think structurally though that there's space for things like PHNs to have more of a role in this kind of stuff and things outside of the prison. So it's not just that little kind of microcosm of prison, and that health's part of the punishment, which, you know, in back in the day, I think we used to think that health was part of the punishment, being away from everybody who loves the punishment, man. We don't put you in prison to stick pins in you and things like that. But it's and the other thing is also we had a working group in Queensland about the fact that crime rates were decreasing broadly, imprisonment rates are increasing. Like, what's going on? You know, what's the perverse incentive there, and is it privatization and things like that? And I've listened to a couple of podcasts by a few guys that were inside in New South Wales prisons who talked about this, who talked about the fact that they thought that everything was set up to keep them in prison as far as they were concerned. These white guys as well. But yeah, look, I think we've still got a fair way to go, but I think through care programs, those thinking therapeutically instead of just punishment wise, and particularly around healing, and for our people, I just think healing programs inside would make a massive difference. And that is our target audience to a certain extent there for healing. That's it for me. Thanks.
Thanks, Mark. And yeah, touched on many things, including that preventing reincarceration too. And Jack, I know there's some threads there for you to pick up on and to acknowledge statements that you've made in that Vic Ombudsman report,
Yeah, sure.
and, you know, sensitivity warning around asking you to reflect on that, but that and other things. So over to you. Thanks.
Yeah. Firstly, I'd just like to acknowledge the traditional custodians where we all work, mate, and play. And I want to pay tribute to where I'm sitting at the moment on Gidable country, and pay homage to my ancestors and my old people as the Muddy people, and just pay respects to all you guys that are here joining us, and pay respects to all our elders past, present, and any up and coming. I guess everything that Julie and Mark said is, you know, just resonates so much with the work that we do at Mibbenbar, and we started off in 2007 as an action research program, and it looked at health access for Indigenous fellas, and what a safe space could do to help that access to health. And so this is pretty close to our hearts with what we do. I mean, we do a lot of work in prisons as well, and we've got a lot coming up in the next 12 months as well, you know. So it's yeah, look, we run a suite of programs at Nimmityjah, and one of the biggest ones is Be the Best You Can Be, where we look at themes from a movie and we work through those sort of things. And as Mark said, I mean, you know, there's from doing work in prison, there's fellas that do, you know, there's good and bad in everyone. So there's fellas that deserve to be there, I suppose. But there's a hell of a lot of fellas and girls that don't belong there. You know, it's just wrong. And the whole thing about this is that, you know, we're not looking at rehab, we're looking at punishment. So the thing for us is that we need to be able to get some sort of rehab in there. So we need to get our programs in there to help our lads and our girls to be able to move forward and, you know, help those future generations that we talk about to be able to, you know, thrive, not survive. You know, this is about us being able to, all of us here, we need to be able to work together to be able to assist people that are in these situations, because a lot of it's, you know, it's, yes, we have to take responsibility for ourselves, but a lot of it isn't their own responsibility. And I think from what Dr. Megan said before about the work that we did last year in the prisons in Melbourne with the Ombudsman's office, I've done a hell of a lot of work in jails over the years since, you know, 2005, to go in there and look at access to health for Aboriginal and Torres Strait Islander males. It just blew me away with the lack of access to health services for these lads, and it, you know, it actually brought tears to our eyes when we were looking back on it. And you know, it was, you know, as I said, I've done so much work in prisons, but to actually talk about access to health and the lack of it and the power that people have that haven't got the necessary skills, the necessary qualifications, and making judgment on people's health, and that's why people are passing away in jails. You know, it's it certainly needs to be looked at, and it's really we're really, you know, big on this, and you know, we want to be able to try and help and educate people on that cultural safety for our mobs as well. You know, there's so much that needs to be done, and so much that's either misunderstood or not understood. And you know, we certainly need to be able to try and get that right. So us being all here, you know, and probably everyone here has been trying to do this over the years, but this is where we all need to get together and be on the one page and work together to be able to you know, get our programs in the jails, because we know that they do work. We know that working with our own mobs is going to help them, not just with the physical health, but with the mental health as well. Yeah,
thanks.
Thank you.
Thanks so much, Jack. And yeah, lots of ground you've covered there, and that we could hear the sort of shock in your voice at what you'd witnessed, and sort of in these current times, and potentially a worsening. And so probably one thing that's resonating in my mind is that Medicare reform is not the answer here. It's part of the answer, it's part of the problem. Could we be as bold as saying that?
Absolutely.
Really?
I think that, you know, I mean, we run a clinic here at Narrabundah, and we can't cover the costs of the doctors from the Medicare claiming, you know, and in the prison we have around 130 men and women, because it's a male and a female prison, and to have that level of resources in there, we get 1.4 million from ACT government to provide our service in the prison. So, and we want to expand because there's a lot of Aboriginal men and women out there that want to transfer from Justice Health to Winnunga, but we don't have the resources, or otherwise, you know, it's a long drawn out process with Justice Health. The other thing is, you know, methadone in the prisons. We chose not to dose methadone in the prison when we went in, because we felt that there was only room for one provider because it had become too messy. So, but we've had a lot of good outcomes where a lot of the men and the women have come off the methadone to go onto Buvidol. And Buvidol's an injection, and Buvidol can't be diverted. So that's been a huge win for us. And in that last 18 months, we haven't had one man or woman self-harm.
So in that time, you think that's part of the role of knowing Aboriginal community control is there and kind of watching, holding to account?
They trust us, the men and women, and our men and women trust us. And like I say to the nurses and the doctors, they're not Aboriginal. And that's why I've got an Aboriginal support person working out there with them, so that they're the conduit between the staff and the inmates. So they, but also when staff pull on the Winnunga top out in the prison, there's already a level of trust, because them men and women out there know that I'm not going to employ people that aren't going to look after them, that don't actually care about them. Because if they're not going to care for them the way that they care for or make judgments, then they shouldn't be working there.
Yeah, absolutely. Yeah, we know, you know, from the AIHW data that people in prison have multiple compounding health issues before they go. Sometimes they worsen, and they can worsen post-release. But when you look at the shape of the workforce in prisons, it does not match. It's a security and good order sort of militaristic workforce.
Yeah.
And they're all military officers from overseas, you know, like that are working in this prison. And we've got the most violent prison in the country, and here we are in Canberra. They've got no programs. They're bored, and, you know, the drugs run freely, and they've banned tobacco, which is a legal substance. And I'm calling for a needle and syringe program in the prison because of the, you know, intravenous drug use. It just sounds hypocritical, doesn't it?
It really does, yeah. Let alone, you know, to achieve the human rights and to go to Jocelyn Jones's question in the chat about, you know, that comprehensive primary healthcare, comprehensive healthcare, holistic care that government says Aboriginal people have the right to by virtue of our cultures being respected. So, you know, how possible is it for that to occur? Jocelyn's asking.
Well, it's got its challenges. When Winnunga went in there into the AMC, we went in there in good faith, thinking that, you know, like, because of the service that we provide, because we still use the health checks, you know, we do on the inside what we do on the outside with our mental health care plans and our health. The only thing that we can't do is claim for it. So we still follow the same processes. We've got the same system, so we use Communicare, but it is a punitive place, you know, and Justice Health can't get nurses, so they use a lot of contract nurses, where my nurses are employed and salaried nurses, so are the doctors. And, you know, it makes a huge difference. And 5 of my 6 doctors turned over during COVID, and only 2 before that wanted to go into the prison. So I had resistance from doctors. So when I was advertising for more doctors, the first criteria was that they had to be able to go into the prison. Now I've got doctors that will go into the prison and don't expect to get paid exuberant amounts of money, you know, like, so for me, but I thought that Justice Health would step up and provide the same level of healthcare that we provide. but actually they've made it like it's a competition. They've actually now setting up units in justice health and Aboriginal units in corrections, when really that money could enhance what we're doing in there.
Yeah.
Sorry,
Yeah.
I think I cut you off.
No, investing that the autonomy of Aboriginal organisations, like you talked about before, that's what was one of the success factors for you, was the autonomy, rather than growing a bigger Aboriginal workforce within government, given government's history of not retaining Aboriginal staff or developing their careers over time, and frequent experiences of racism. We don't have those same data. We've got almost the opposite data from community-controlled health organisations, Aboriginal workforces.
And
Yeah.
Megan, the other thing that I think that's really important that Julie talked about was having that health IT system as well that follows the prisoner inside and outside, because look, we'll diagnose, you know, new diabetics and all sorts of things inside prison, but the chances of them getting followed up outside are slim, because there's very little, there's not always good two-way communication between a prison and where somebody's home community is. And the other thing is that prisoners can get released just any time. Like,
Yeah.
suddenly they're released and stuff like that. They're in a different town, and nobody knows. The H block, the health people don't even know they've been released, let alone, you know. So it's a different system, and it needs different ways of making sure that we're, and Julie's kind of cut that, you know, like it's just cut that off at the knees by having them all on the same IT system, so it doesn't matter where they go. They can still follow them up, but those kind of things are really important for following up prisoners, you know, ex-prisoners, I should say, as well, particularly when often we start doing a lot of work on health inside, because there's not much else to do, and so lots of guys will want to do work on their health, but if we lose them straight away, it's a shame, because they go straight back into bad situations and they lose all those good health as well, you know.
Yeah.
And we lose all that investment that we've made as well. You know, don't want to make it about money, but like, you know, we make an investment in these guys, and we can get good returns in social capital in our communities, you know.
Yeah.
Winnunga gets $15 million a year to run our service, and 1.4 million to run a service in the jail. Corrections get over $100 million a year to keep mob locked up. $197,000 a year here in Canberra to keep a person locked up.
Yeah.
Imagine if we got that funding, what we could do, you know. And the thing is, people need to understand, a lot of these men and women, they were victims before they were perpetrators. And you know, what we're dealing with is poverty, trauma, and addiction, you know. And so politicians have got to stop saying that if they're not going to be serious about funding rehabilitation centres or otherwise providing that on the inside, they've got to stop agreeing with us that addiction and mental health are health issues. So you can't have it both ways. We've got to stop locking people up when they've got issues around trauma, addiction, mental health. And poverty.
Interesting too. I think some of the international models of corrections as well, where the people inside are completely advocates for the prisoner. Security is run by security services, but the people that work in there. So the nurse that I'm working with can't start thinking that she's part of the prison and start using rusty syringes, if you know what I mean.
Yeah.
It's if you're an advocate for the patient in some of those systems, you stay an advocate for the patient. Like, and that's the way nurses and doctors always should be with patients. Like, we never should be an advocate for the system over the patient ever. Like, you know, but in the prison system, it kind of swaps around that a bit,
Absolutely.
and it's part of that, you know. But it's really important that we're not part of punishment. We're in there to help people. It's really important that our men and our women understand that, and they do. Look, you know, honestly, when our services go in, it's like we all know each other already. You know, like it's not something new. So there's a level of trust and understanding there already, and we use things like as well traditional healers and stuff like that. on the inside, which really can really be helpful for a lot of our as well.
I
So
was going to ask about
sorry,
differences for Aboriginal and Torres Strait Islander people in this discussion about Medicare and people in prison. You know, like what important considerations for mob should we be remembering and put forward compared to general population? So things like holistic. What else?
Hey, look, there's a couple of things there's one thing that came up in the last coronial I did, just age. You know, our epidemiology of disease is a lot younger. So someone said, oh, well, would you send somebody who's, you know, got chest pain who's 25 for a ECG and stuff like that? And I said, yeah, if they're Aboriginal, definitely. Like if they're our mob, it's a heart attack or a stroke to prove it otherwise. And in the other population, if they're below 50, it's just not a high risk thing, you know. But for us, so many of these things we're very super sensitive to. So it's really important. But not only do we have a good service in there, but clinicians that are bloody good, not ones that ignore you. You know, like you need clinicians that their ears will pick up when an Aboriginal man says, I've got chest pain and they're 22, you know. They're not just saying, no, it's just going to be reflux. They're going to say, no, that lad, there's a whole different set of risk factors that come in with these population here. That fellow needs an ECG right now. Those kind of things are really super important, and mainstream services cannot pick that up because they don't work that way and they're not used to working that way. And these are a specific population that we know very well. We know the epidemiology of disease in our populations very well. We know their social stuff very well. And we probably know most people's families as well pretty well, you know.
Yeah, thank you. I think that's just a astounding reminder that when we do discuss Medicare and prisons, we also remember the cultural lens and the particular issues. And Lois Peachy's put in the chat a pretty horrific sort of statistic about children being much more likely to die than children their own age, and it's that same point. That's tragic. Jack, sorry, did I cut you off?
I just wanted to go back to what Mark said before about healing and how important it is for our mobs to be able to get that side of it, you know, that the cultural appropriateness that needs to happen. And you know, it's such a big thing, you know, like, yes, there's, you know, certainly what you're talking about, Mark, with the physical side of things, but there's also, you know, when we don't get, and we don't feel safe in that environment, it really is hard, and it starts to muck with people's mental health. And I think that goes a long way to helping our, you know, not just our mobs, but everyone that is in prison needs to be able to feel safe, but they also need to be able to work with their own cultures and be able to allowed to do that. And I think the other big thing from doing that work last year, you know, I don't think that these should be places for, you know, to make a profit on. I mean, we need to look at the human side of things and be able to work with that rather than trying to make big dollars off it as well. So
yeah, it's a tricky one, the dehumanizing nature of prisons too, isn't it? You know, globally, and we know globally that they can worsen health. So yeah, we're coming up for time, but yeah, Julie, what do you make of it? And
look, I think that, you know, I would encourage all ATJOs that have got a prison in their particular area to engage. And, you know, at the end of the day, those men and women are going to come back into the community, and we want them to come back in a better state of mind than when they went in. And that's, you know, our priority is to, you know, prisons aren't pretty places. And, you know, the men and women in there, they're the most beautiful, respectful, the majority of them, people that you could ever meet. And they're much more compassionate and caring and respectful than some of the people that I know on the outside, or a lot of them young people. And, you know, they've just had really hard lives and they just keep getting punished. And it's got to stop, you know, like people making judgments. And, you know, when you hear the stories, it's heartbreaking, you know, like people actually, I've heard so many stories from families, but have been involved now in another death in custody of a young man that died in New South Wales earlier this year. And it's just heartbreaking, you know, like, and to think that you gave advice to Justice, Health and Corrections about his mental health that wasn't even taken on. They ask us for our advice and then they don't take it. So don't bother asking us if you're not going to take it, you know, like that's just the way that I feel, you know, like, and a lot of them are there through no fault of their own. It's what's happened to them in their life. And they've come from juvenile detention where they've been abused. They've turned, you know, they've come from violence and all that sort of stuff. And then, you know, they go into a more violent environment. All prisons do is breed violent prisoners. And when I noticed that when these fellas come out, their next crime is more violent than the first one that took them there in the first place. So until we start to do some real work, if they're going to talk about addiction being a health issue, well, let's start working in the prisons properly and let us get through the doors to be able to do that, because, you know, without the pushback that we get.
Yeah. And then that I've never heard of any like critical incident debriefing, you know, for people when they get out of prison, from that exposure to violence in prison, the removal from family, separation from kids, the whole horrendous experience visiting with kids too. So that, you know, the care, what is there a role for Medicare in caring for people as they exit prisons back to the community, a certain type of, you know, schedule or something, in the context that we know that's not going to be enough as well.
Well, like, it's even like NDIS and everything, really, you know, we talk the talk, but, you know, they don't seem to be able to walk the walk. And it's just like it's more punishment. And even, you know, banning tobacco. You know, we know that tobacco is not good for you, but I prefer that somebody having a bunger than just, you know, using illicit drugs. And illicit drugs now are cheaper than what tobacco is. It's $30 for a rollie. You know, that's about $4,500 for a packet of tobacco. You know, people are making big money out of these fellas in prison. And the other thing is that they're running up debts and they've got no money to pay. Well, you know, someone's got to pay at the end of the day, and this is what happens. It's risky and it's challenging, and, you know, if it's not the families, then they get caught up in other things when they get out, and it's just got to stop.
Yeah, it just speaks to actually the sort of bigger issue of frameworks, needing frameworks for this area that map human rights commitments and government's commitments, that maps funding, that maps workforces, and then things like harm reduction as well. You know, those sort of principle-based approach to, rather than this sort of simple message that people in prison need Medicare, but people in prison need actually for their current rights to be achieved, for workforces to do what they currently say they will do, accountabilities as well. There's a lot that should be already occurring that's not occurring, and Medicare is not necessarily going to fix that. Well, that's my summary anyway, and with just a few minutes left to go, I did want to go back to each of our panel members, and if you'd like to just say parting thoughts as we extend our gratitude to you for you being here today. Shall I go to you, Julie? Any parting thoughts as we end the session today?
if I can unmute myself. Yeah, I just think that people need to take prison health more seriously. And, you know, there's people out there that think that, you know, you should lock people up and throw the key away. Well, you know, that's not the case. And like Dr. Mark and Jack said before about, you know, like definitely there's people that probably should never get out, but there's a lot that really shouldn't be in there in the first place. So, you know, if we had better services on the ground to be able to support people and our mob, and, you know, here in Canberra, identity is a huge issue, you know, and they're turning to other cultures, and that's challenging as well, you know, like, so we're about to build a residential rehab, and it's going to be a cultural rehab, not necessarily clinical or you know, they know why they're in jail, because, you know, they've got drug and alcohol issues, but it's more about, you know, their identity and giving them strategies to deal with the triggers that cause them to want to use, and also about triggers around associations, because associations are a big part of it, especially when they turn up to probation and parole. There's always a dealer around the corner. So, you know, it's about practical and domestic violence, you know, anger management, all of those things, you know, they're the things that we should be working with these men and women on, not just the same old, same old. We know it doesn't work, so why do we keep doing it?
That's right. Yeah. And then that sort of multi-level empowerment, working with individuals and families, services and systems, all of those simultaneously. And that's holism too. Yeah. Yeah. Mark, parting thoughts from you, and many thanks.
I just think prison reform is, we have the ability to do it. I think our eyes shouldn't glaze over when we start talking about these kind of things in Medicare and prisons and stuff like that. I think this we should be able to really start innovating and thinking through what the hell we're doing with our humanity when we're just locking up people, particularly in population groups like ours, where it's completely exponentially out of, you know, range from what it should be for a population our size. That's just out of control. So there's got to be better ways, and there are, and we're just not innovating, and we're kind of happy with the status quo the system is anyway. But there's no reason why it should be the same, and I think we can change it.
Yeah, awesome. Thank you. Thank you. Jack, have you got?
Yeah, I mean, I agree totally with Dr. Mark and Julie. I mean, I think there's a lot of people that don't understand what goes on and it's like it's out of sight, out of mind, you know, those sort of things. And I think that we can do a lot better with helping our men and our women, you know, just to get back to some sort of normality. And, you know, as Julie said before, you know, it's cost $197,000 per person. I mean, surely that money can be better spent going to programs that are able to help. And you know, if we can start to do that, I think there is a way forward. And I think that it's going to take a hell of a lot, but it's going to take all of us working together to be able to achieve that. So yeah, so I mean, and the other thing I just want to touch on, and Julie said beautifully before, was about, you know, that identity, and it seriously, we see it wherever we go, is that whole sense of belonging and the identity that crushes people, and it just destroys people. And you can understand why, you know, they go down certain paths as well. So yeah, it's something that we need to be all working on together, is that helping people with that sense of belonging and that identity.
Yeah. Well, in terms of working together, I think around this screen with the panel members and participants as well, yeah, we've got a lot of ground covered. And I thought to just end with a quote of Tracker Tilmouth, Aboriginal leader, and Alexis Wright's extraordinary book about him. And I love this quote that Tracker always looked at the bigger economic picture, larger than the actual reality for Aboriginal people, which he frequently called the vision splendid. He immersed himself in it, engaging with all the battles. And I think today we've named probably all the battles. We've got panel members who've been through all the battles and other participants online. The solidarity is just crucial, bearing witness to what's going on in prisons, in services and in policy, the closing the gap overlay with its priority reforms and the opportunity for accountability there. Don't for a moment take your eye off that in relation to prison health. And stay connected, supporting Croakey's work, sharing information, articles, and being available to continue the discussion too. So from Croakey and from me and on behalf of the panel members, thank you everyone for coming along. And can we just give a few shout out thank yous for Julie and Mark and Jack as well for your contributions, and others here. We're indebted. I'll call this to a close, but feel free to stay in touch in the many different channels. Great to see you all.